All right, let's get started. Thank you guys all being here on a Friday. I know it's unusual for us, but have to make up for the holiday, right? Then you think, don't really get a holiday, right? So that's what I thought. I was like, well, why did I do that? Why did I do that to y'all and myself? Okay. All right, so we're moving on into lecture 16. So we've talked about the donor collection process and how whole blood can be separated into different components. Now we're going to look at each of those components. We're going to talk about what conditions they are used to treat. We're going to talk about what storage temperatures they need to be kept at, and we're going to talk about expiration times. So expiration times and temperatures, very important. You guys have to know them, all right? And so I'm going to try to go, as we go through these, I'm going to try to give you easy ways to remember what each is stored at, all right? All right, so you guys, we talked a little bit about whole blood. Used to, before component therapy became a thing, you would donate a unit. It had your red cells, it had your plasma, it had your white cells, and your platelets. That's whole blood, all right? Used to, that would be all that we had. And so when a patient needed a transfusion, they received that whole unit, whether they needed the plasma or not. Maybe they were just anemic and just needed the red cells for the hemoglobin and oxygen carrying capabilities. However, as donation centers and advancements in blood banking has progressed, we now can divide that whole unit into separate components. It has really enabled patient treatment to advance as well, because we can treat the specific condition, whether it be just the anemia, or maybe it's a coagulation disorder and they just need FFP, or now we've even come even further. If they do have a factor deficiency, now we even have recombinant DNA concentrates for that specific factor, rather than being exposed to a donor unit of plasma. So you can see how kind of the transfusion has advanced over time. All right, so, and there's a huge movement in blood bank. It started several years ago, and really trying to minimize the amount of products that patients are exposed to. Number one, because of the risk of infectious disease. And then number two, they do get sensitized and can build alloantibodies. So if we can minimize that exposure, then it could ultimately benefit the patient for their overall health experience. Okay, so there's a huge movement right now to minimize the amount of transfusions. A lot of hospitals, and we'll talk about this, have even developed a threshold for, like, if you have, your patient has a hemoglobin of 10, then that does not warrant a transfusion of red cells. The hospital might say you cannot transfuse your patient until that hemoglobin drops to between 6 to 8, depending on what patient population you have. If you have a lot of sickle cell patients, they might want that hemoglobin to be at a lower than a 6 before they transfuse those patients. Just because sickle cells naturally have a lower hemoglobin. Now, unless they're in crisis, of course, then they'll probably have a red cell exchange, which we'll talk about later on as a special blood bank procedure. But we talked about you can obtain many components from that one unit of whole blood, and we're going to go through each of those components. All right, so here is an example, and I kind of told you guys, so this is a whole blood unit here, right? So after the donation process, here's your whole unit, has been centrifuged, all right? So notice that your red cells fall to the bottom. Here's your platelets and your white cells. That would be known as your Buffy coat, and then your plasma. So that's what we are looking at after your unit is centrifuged. And notice this is actually in one of those expressor things that I showed you guys a picture of. I don't know a better word for it other than expressor. So it has like a lever that you pull back on and opens up. Then you place the centrifuged unit in there, and then you have your tubing connected to a satellite bag or a smaller bag, and then you will squeeze out, and you are visually watching for when all of the plasma had been pulled off of that unit. Okay, so it's not very scientific, this method. Again, you're using your human eye to estimate when all of the plasma has been pulled off. So, and remember, after that point, Here's one of those expressors that I was talking about. After that point, when you are left with just your red cells, that is the point that we can add our preservatives, such as Adsol 1, Adsol 3, Adsol 5, and now there's Adsol 7. So that's that point. Remember, the preservative is only added to the red cells because it will extend the shelf life of your red cells to 42 days, okay? So in this diagram, we are at this point right here. Notice that our platelet-rich plasma has been expressed off, and then we can add Adsol 1 to our red cells. Okay. In the past, I feel like this course hasn't done a very good job of differentiating anticoagulants and preservatives. So I really want you guys to understand anticoagulants are already in your parent bag, all right? CPD, CPD2, CPDA, whichever anticoagulant is in the parent bag. And then you have the option, once the plasma and platelets are pulled off, you can add the preservative, which is your Adsol, extending those life of the red cells, all right? That's the difference between anticoagulant and preservatives. All right, so this chart is in your textbook. It highlights all of these storage requirements, all of the temperatures, and the expiration times. So we're gonna go through each of these, and I want you to break these products down. So anytime you have red cells, they are required to be stored at refrigeration. Refrigeration temperature must be between 1 and 6 degrees, okay? So I like to say 4 degrees, that's a average refrigerated temperature, all right? If at any time your refrigerators, whether you're storing red cell units or reagents, goes out of temperature, whether it goes too cold or too warm, you have to completely move everything out of that refrigerator into another location to figure out what's going on with that refrigerator, get it back in temp. And it has to, once it gets out of temperature, it has to come back into temperature. Maybe you have to add more refrigerant coolant to it or something. It has to stay within that temperature for 24 hours. All right, and you will have to monitor that temperature. A lot of blood bank refrigerators have a automatic temperature check built in, so it checks it every hour. If you don't have that, you have to manually check that temperature every hour. All right, and we'll talk about all that when we start talking about quality control in the blood bank. Temperature is a huge concern in blood bank because these products are going to be transfused into your patient. So we are constantly worried about temperatures, okay? Whether that be refrigerated, whether that be room temperature, freezers, ultra low freezers if you have those, right? So we will always monitor our temperature in blood bank. Frozen, so anything that is frozen, such as frozen plasma, cryo, a normal freezer needs to be maintained at -18, right? So if you're ever concerned about what temperature your frozen products need to be at, it's -18. And so fresh frozen plasma, when stored at -18, is good for 1 year as long as it stays frozen. However, you can freeze it at an ultra low temperature, meaning -65 to 70 degrees Celsius, and then that extends the shelf life to 7 years, okay? But then once you thaw it, your expiration date changes, all right? So as long as it stays frozen at -18, 1 year, -65, 7 years, okay? And then actually, we're going to talk about the process of freezing red cells. You can freeze red cells. You can add some glycerol to them to prevent the cell lysis. And they are able to stay frozen at -70 degrees for 10 years, right? And when I say 10 years, that's from the date of collection. So from the phlebotomy, all right? So when we say expiration days, it's good for 35 days, it's good for 42 days, it's good for 1 year, 7 years, 10 years. That expiration date is from the time of collection, right? There are some disclaimers that, like, if you thaw plasma, then the expiration changes from the time of thawing, all right? If you pull platelets, then your expiration time changes from the time of pulling. All right, and we'll go through all of those. All right, so whole blood, and again, whole blood is seldom used now. You probably in my blood bank experience here at UAMS, I only saw maybe 2 units of whole blood. All right, so you just don't see it very much because components are such a more appropriate therapy, a specific targeted therapy, if you will. All right, so whole blood, typically, you guys all know a donation is usually about 500 mils. And again, it's going to contain your red cells, your plasma, your platelets, and your white cells. Usually for a whole blood, you have a total hematocrit of anywhere from 36 to 40%. And again, this is stored at refrigeration temperature, 1 to 6. So with that being said, one of the limitations of whole blood, anybody know what happens to platelets when you refrigerate them? Your platelets are inactivated, all right? So one of the limitations to whole blood is those platelets are no longer viable after refrigeration, all right? As we will talk about in the next lecture, platelets are kept at room temperature, 22 to 24 degrees Celsius, all right? So they should never be refrigerated, okay? So when they are refrigerated, then they're no longer viable. So whole blood doesn't really benefit your patient if they are needing platelets, all right? So that's another reason component therapy is more beneficial. And then remember, depending on what anticoagulant is used determines your expiration time, all right? So if CPDA1 is used, that's a 35-day expiration. If you use CPD or CPD2, that's a 21-day expiration, okay? And remember, we will not add Adsol to whole blood. Okay, so Adsol will only be added on to packed red cells, which we'll talk about in just a minute. All right, so when could you use whole blood? Anytime you wanted to replace oxygen carrying capabilities and volume, all right? So that would be an example if your patient has undergone a massive blood loss. So in the examples of traumas, you want to make sure you could use whole blood in those situations. There's a lot of, you might hear this in the news or in articles that you read, the military is actually looking at going back to whole blood transfusions. And so that's a new blood bank topic right now. Research is actually undergone on that. So whole blood might actually be making a comeback. But for the clinical hospitals, usually you're going to have specific components. For exchange transfusions, this is a pregnant mom. The baby is in distress, whether it be due to a high titer antibody that is coating baby cells, and they want to pull off those cells and give her fresh donor cells. They might use whole blood transfusion in those instances. That's another instance. All right, so a unit of whole blood should, in your recipient, after the transfusion, you guys need to know this, it should raise your hemoglobin by 1 gram per deciliter and or raise the hematocrit by 3%, all right? And so this is how transfusions work. Let's say you have a patient that presents with a very low hemoglobin, maybe their hemoglobin is 6 grams per deciliter. You give them a unit of whole blood. That hemoglobin after transfusion, about probably 2 hours post-transfusion, that hemoglobin should be up to about 7, all right? I would not be surprised if it's even at 8. That's how you can gauge if that transfusion was successful or not, right? Does that make sense to everybody? So oftentimes, as you guys start working in the clinical hospitals, you'll have physicians that order H&H on patients like every 4 hours, every 6 hours, every 8 hours, and especially if they're monitoring like an anemic state or anything like that, all right? And it's not uncommon for blood bank and hematology to talk to each other. So hematology is going to be performing these hemoglobin and hematocrits, and if they have a delta check, meaning that yesterday the patient's hemoglobin was 6, today their hemoglobin is maybe 9, did that patient receive transfusions? All right, blood bank's going to want to call you. They're going to say, hey, can you tell me if this patient received any red cell units and how many? All right, so that's a way the clinical laboratory works together to explain patient results. There are some limitations to whole blood. We already mentioned one, there's no viable platelets, all right, because of the refrigerated temperature. Remember from coagulation last semester, Factors 5 and 8 are termed the labile factors because they tend to break down very quickly, especially if you store them at refrigerated temperatures. So that plasma that's contained in whole blood does not contain 5 and 8, all right? And then your granulocytes also will no longer be viable because of that refrigerated temperature, okay? And then circulatory overload. A lot of patients really just need the oxygen carrying capabilities. All of that excess plasma can overload their circulation system. Something you guys need to know about whole blood, keeping in mind that it has red cells and plasma. When you transfuse whole blood, you have to give ABO identical, all right? That's different from ABO compatible. So if you gave a patient a group O whole blood, all right, think about what's in a group O patient whole blood, anti-A and anti-B. So your donor anti-A is going to attack your recipient A cells, okay? That would be a transfusion reaction. That is why whole blood has to be exact ABO match, okay? Versus if we're just given red cells, we can give an A patient A cells or O cells, right? Because it's only the red cells, no ABO antibodies are involved. Okay, does that make sense to everybody? Okay. So then you have one of the components from whole blood is your red cells, all right? Think of red cells, you might also hear them referred to as packed red cells. Some people even will just say RBCs, all right? That is packed red cells, only the red cells. And this is formed after that soft spin of the whole blood unit. You're left with your red cells. So your volume depends on the anticoagulant or your preservative. You should have anywhere from 250 to 350 mils. And then depending on if you just have anticoagulant, so you have more red cells, less additives, then your hematocrit should be approximately about 75%. If you add Adsol, think about that. You're further diluting those cells, the hematocrit is going to go down, right? So usually if you add Adsol, your hematocrit goes down to 55%. However, there are some studies, if you research this, that say addition of Adsol not only prolongs the shelf life, but also makes the process of transfusing these red cells easier. Those red cells are less concentrating, more liquidy, and then when you add the saline during the transfusion process, it makes it entering the patient a lot more simpler. And you guys can research that. There's articles out there about that. All right, so red cells, we're still at that 1 to 6 degrees Celsius temperature, so this is refrigerated. And then your expiration date is still dependent on anticoagulant and preservatives, all right? So if you have added CPDA, your expiration time is 35 days. If Adsol has been added, then your expiration time is 42 days, okay? So the expiration date of whole blood and red cells is dependent upon what anticoagulant is in that unit and if preservatives have been added to the red cells. Okay. In blood bank, and I mentioned this before, we're concerned a lot with bacterial contamination. We don't want these units to be contaminated prior to being transfused into the recipient. That could cause your recipient to be septic, all right? So anytime you access the port, and I wish I had a picture of what a port looks like. It's really hard to see. You can see one right here. So this is a port. See how it's sealed off? When they get ready to transfuse, they will peel back and access the unit. They can spike it with their tubing. That is accessing the port. Anytime you access that port, it changes your expiration time to 24 hours. And that's just because of the risk for bacterial contamination. All right, and so that aligns with some of our other expiration times in blood bank. Anytime you wash a unit of red cells that we're going to talk about, you have accessed that unit, changes your expiration time to 24 hours, okay? So when would using red cells be appropriate? We've mentioned this before. If your patient needs hemoglobin increase, oxygen carrying capabilities, maybe they've been involved in an acute or chronic blood loss situation, we're more worried about their oxygen carrying capabilities than their overall circulatory volume, red cells is the most appropriate therapy for them. Now, this says transfuse when your hemoglobin is 8 grams per deciliter. Now, each hospital will have their own established threshold. So this says 8. I would not be surprised if some hospitals have a lower threshold even at 6. All right, and then you also have to take into consideration what the status of your patient is. Are they a known sickle cell patient? Do they have a chronic GI bleed? What's going on with that patient? But that threshold should be about 6 to 8. And just like whole blood, red cells will increase your hemoglobin by 1 gram or your hematocrit by 3%. And the only limitations with red cells, it contains no platelets, granulocytes, or any of the coagulation factors. All right, so it's just strictly oxygen carrying capabilities. Some advantages for using only red cells: no likelihood of antibodies from the donors to react with recipient antigens. All right, so you're just dealing with red cells. You don't have to worry about donor antibodies from the plasma, okay? That's why we can give ABO compatible for red cells, okay? And again, circulatory overload, because that we're not giving them plasma either. So your textbooks list some common populations of patients that need transfusions. If any of you guys work at an institution where you have a population of cancer patients that are receiving chemotherapy or radiation, we all know their white cells, their platelets, their red cells are going to be completely wiped out. They will have multiple transfusions. You will see them. You will feel like you know them. All right. You will do multiple workups on them. Some they might even come in every day just to receive their transfusions. All right. So if you have any leukemia patients receiving chemotherapy, trauma patients, if you're at a hospital that has an ER or an OR and your patient's bleeding out, they will receive multiple products as well. Surgeries, if your hospital does surgeries, then you can guarantee that they will receive transfusions specifically in cardiac cases, orthopedic cases, any type of vascular cases such as an aortic aneurysm, anything like that. Those are your bleeding cases. They will use products. End-stage renal disease, if your patients are on dialysis, they will have transfusions as well. If you work at a facility that has a NICU, you will be involved in preparing neonate transfusions as well. They have special requirements that we'll talk about in a future lecture. And then sickle cell anemia, or even your thalassemia patients. So your thalassemia major patients that receive multiple transfusions as well. All right, so what does this mean for blood bank? What type of workup is involved? All units must be, now we're talking about red cells, right? Okay, so they must be ABO and RH compatible. Okay, so we will always test for that D antigen. Your recipient must have an IAT performed, so that screen, all right, we're looking for any unexpected alloantibodies, and a cross match. All right, in a future lecture, we'll talk about the types of cross matches. There's initial spin cross matches. There is AHG cross match. And if your lab has a computer, your computer can perform the cross match for you. There are some restrictions on that we'll talk about. All right, your patient can't have any ABO discrepancies, can't have any previous antibodies identified, and their current IAT must be negative, and you have to have an established history on them as well to confirm that ABO. All right, so we'll talk about that. Sarah asked, what is that like HCLL? Oh, yes, that would be your blood bank system. Yeah. Blood bank systems, I probably can't think of any off the top of my head. Citrix. What's the older one you used to use? There's several different blood product management systems. So at UAMS, they had their blood product management system, and then they had their electronic medical records, where all the patient history is located. The two did not talk to each other. So you would have to look in Epic for your patient history, diagnosis, and all that stuff, but your lab results were entered in, I can't even think of what system it was. It was in the other system. All right, and then make sure your units, so at the donor facility, your units would be ABORH tested, IAT testing, and then all of your infectious disease testing. Okay, so we can actually modify these red cells to better accommodate specific patient populations. Okay, and so when I say modify, we're going to do something to them that changes their attributes, all right? That includes we can leukoreduce, right? So we can remove the white cells, we can wash, we can irradiate, and we can freeze, okay? Anytime you do these, it changes the type of unit, all right? It changes it. So if you have a computer system, then you have to enter this attribute. So if you irradiate a unit, it could potentially change the expiration date, and then it changes you have to add on a attribute that says this unit has been irradiated. Okay. All right, so leukocyte-reduced, exactly what it means. The white cells have been removed. And it says that 99% of the removal of white cells by filtration. So what happens is, I put a picture in here for you guys to understand. I want you guys to understand this occurs in the donor process. Okay, so after the collection, it's going to be filtered. And notice, here's your, let me use my mouse. Here's your original red cell units, all right? They've attached some tubing to it. So here's your filter. It's going through a very small pore size filter. The white cells will get trapped in this filter, all right? And then you're left with this remaining red cell unit, leukoreduced red cells, okay? I want you guys to understand this occurs in the donor process. During the transfusion process at the patient bedside, it will also be filtered, all right? It's a 170 microgram filter that will be used on red cells, platelets, and platelets. That filter is only to collect like any type of debris or trash that might have been in that unit because it has sat in storage for an amount of time. That filter only collects debris, all right, and that kind of stuff. Any kind of fibrin that might be collected in that unit over the storage, all right? So this is different than the filtration that occurs at the patient's bedside prior to transfusion. I want you guys to understand that, all right? This is removing the white cells specifically. Now I say that, however, we're gonna talk about graft versus host disease. Graft versus host disease is caused by T lymphocytes, all right? So the very small mature lymphocytes can survive this process. It's known, all right? So leukoreduced red cells does not prevent graft versus host, okay? If we want to prevent graft versus host, we need to irradiate, all right? We'll talk about that in a little bit. All right, so remember I talked about sometimes when we alter the unit, it changes the expiration date. Because leukoreduction is done in a closed system, all right, this filter in the extra bag is attached to your mother unit using a sterile docking station. So it is still considered a closed system. Your expiration date has not changed, all right? And just to let you guys know, if you've never seen a sterile docking station, this is what it looks like. You can add your bag that already has the unit on one side. Your new tubing with the new bag attached is added on the other side. You have these copper wafers, sterile wafers, that are in here. You push this little lever, it loads the wafer right into this region right here. It uses heat to heat up that copper. It will melt the tubing and then fuse them together. All right, keeps it sterile, and now you have these bags connected together, and that is still considered a closed system. All right. So when would you use this? Whenever you're preparing neonatal transfusions, if you are pulling cryo, pulling platelets, you could pull your all your bags together. Leukoreduction, and then if you need to remove some samples for testing. So remember, when we do our testing in blood bank, you don't want to access that unit. When we access the port, then that changes the expiration time to 24 hours. So we can, there's going to be blood in the tubing of your unit. We can seal off little segments of the tubing, and then we can use that blood that's in the tubing for our cross matches phenotyping. Okay. All right, so when do we use leukocyte-reduced red cells? So when we start talking about transfusion reactions, there is a classification of transfusion reactions. It's called febrile hemolytic transfusion reactions. And usually that is caused by HLA antibodies found on white cells, or sometimes even found on platelets. So by leukoreducing these red cells, getting rid of the white cells, reduces the exposure to these HLA antigens, therefore reducing the HLA transfusion-related reactions, okay? Part of the workup when you do a transfusion reactions, if you have fever involved, if your recipient spikes of fever, we have to, number one, we want to make sure it's not due to ABO, which would be a hemolytic transfusion. And then an acute hemolytic transfusion. And then you want to make sure that it's not due to another allo antibody. And then most oftentimes, if your patient has spiked fever, it's probably due to HLA antibodies. Now, I will say leukoreduced used to be like a special attribute you would have to order because it is an additional cost. It's another step in the donor collection process. However, now, at UAMS, we only keep leukoreduced. We don't have any other products. And just because of the HLA antibodies, and we haven't talked about HLA yet, but we have a whole lecture dedicated to HLA inheritance patterns and when to use them for bone marrow transplants and or like liver transplants and things like that, okay? Leukoreduced, and I kind of already mentioned this if you guys remember in a previous lecture. Your CMV, the cytomegalovirus, is usually transmitted from your monocytes, right? So if we can reduce the amount of white cells in our donor unit, then that reduces the likelihood of CMV being transmitted. And you guys remember, for the requirement, some of our donors are tested for CMV to see if they're CMV negative. And we require that for babies. If you're going to transfuse a baby, it has to be CMV negative. However, leukoreduction has kind of replaced that now. If we can get rid of those white cells, then the likelihood of CMV being transmitted has also decreased. So leukoreduced has replaced the requirement for CMV negative. Okay. And so really that's only a concern in immunocompromised patients, such as our neonatals. If you had anybody on chemotherapy, any type of immunocompromised patients, the transmission of CMV is a concern because it's just like the normal cold symptoms. You and I could fight it off, no problem. But if an immunocompromised patient gets CMV, it's a huge concern for their immune system because they don't have the cells or immune system to fight it. All right. Like I mentioned, it is a little more expensive. That's one of the limitations. It does not prevent graft versus host. And there is research that says that getting rid of the white cells, because our white cells are the ones that release cytokines. So it is thought that you could reduce the amount of transfusion reactions by getting rid of those white cells. So that further prevents our transfusion reactions due to the HLA antigens on those white cells. All right, so that's leuko-reduced, all right? We can also wash our red cells. And what this is gonna happen is, this too will also remove some of the white cells. However, it is not near as efficient as leuko-reduced, okay? An example when you want to wash your red cells is if you wanted to remove any, there's going to be a little bit of plasma remaining in those red cells, probably about 20 mils. You could wash red cells if you wanted to remove that remaining plasma, right? It's just like you guys washing and making your cell suspensions for your testing. You're just doing it on a larger scale, all right? You would want to wash if you have a patient that has an IgA deficient, meaning that they could potentially build anti-IgA. It could cause them to have, if they were to be transfused, they could have an allergic reaction to that transfusion, an anaphylactic reaction. So by washing their cells, we remove the IgA from the donor unit, prevents them from having an allergic reaction to the transfusion. It used to be where washed products were warranted for patients with paroxysmal nocturnal hemoglobinuria. You guys remember that from hematology. These patients lack the CD55 and the CD59 on their cells. Therefore, those cells are susceptible to lysis by complement. So it was thought that transfusions could stimulate these cells, could stimulate the MAC, and could stimulate complement, and then these cells would be lysed. So our patient was having a lysis crisis because of the transfusion. So it's thought if we washed the cells, then that would prevent them. That is not routinely done now. We don't typically see a lot of washed products for PNH anymore. All right, after you wash, that changes your expiration time to 24 hours, okay? Because you have to enter that unit in order to wash the cells. And just to give you an idea, I wanted you guys to see what a cell washer looks like. This one right here is actually a cell washer from UAMS Blood Bank. All right, so this is what they look like. Notice there's a lot of dials, a lot of buttons, a lot of tubing. So notice here, this is our donor unit red cells that we were washing, all right? Inside this little unit right here, I wish I had a picture. It's like a donut. It's a circular donor collection unit. It fits inside there, and it's clamped in. And then here's your saline. So usually when you perform washing, you use 1,000 to 2,000 mils of 0.9% normal saline, and you wash them, and then everything's color-coded. A lot of students get overwhelmed at all the tubing. It is overwhelmed. It's all color-coded, kind of helps you know what tubing goes where and how to hook it up. And then so blood is pulled out of your donor unit into this middle part here, and this middle part centrifuges, all right, so it spins, and then once all the red cells, and here's your sensor right here, so it can sense when the red cells have stopped flowing into your donut bag in the middle, all right, so once your cells are in there, it's going to centrifuge it, then it's going to add saline, and it's going to do a series of washes, it's going to use all of that saline, and then it'll add a series of saline, it'll agitate it for a little while, and then it'll centrifuge it, and then it will aspirate all of that saline out. There's a waste bag hanging, it must be on this side, you can't see it. And so all of that saline goes into the waste bag, all right? And it'll do that, depending on how many settings you have, it'll do that to use all of the 1,000 or 2,000 mils of saline. And that is a washed unit, okay? Here's a close-up here. Here's where your donut is, here's your donor unit, your saline, and then here's your sensor in the middle, and here's all your adjustments. You can tell it how long to wash, how much saline to use in each wash, and you have some lights here that'll tell you, okay, this setting is done, I'm ready to go on to the next one. You have to manually tell it that it's ready to continue. All right, so we can also irradiate. We will irradiate to prevent graft versus host disease. So remember, I said that leukoreduction, you will still have some very small mature lymphocytes remaining after leukoreduction, okay? It's a known occurrence. So in order to prevent graft versus host, we will irradiate our blood. I don't know if any of you guys know the symptoms of graft versus host disease, but it's better to prevent it than try to treat it. So once your patient develops graft versus host, they're going to have fever, they're going to develop skin rashes, they're going to get diarrhea, it could cause them to, their bone marrow could become hypoplasia, and then ultimately it could end up in death, all right? So it's easier to prevent it on the forefront than try to treat it afterwards, okay? So what happens in transfusion associated graft versus host, you might see it TAGVHD, all right? You have your donor lymphocytes, if not irradiated. And the huge concern is if those lymphocytes have the same HLA haplotype, okay? Those lymphocytes are going to, your donor lymphocytes are going to launch an immune response against your recipient tissues. Okay, what happens is if the HLAs are the same, then your recipient is not able to destroy those lymphocytes as in a normal situation. So then your body is destroying the tissue. So this is not only a concern for transfusions, but anytime there's an organ transplant, anytime there's any type of tissue graft, anything like that, graft versus host disease is always a concern. And that's why. So that's a huge concern if your patients are immunocompromised. And if they are receiving these products, more than likely, they're immunocompromised, all right? So that's a huge concern. We can irradiate to prevent those T lymphocytes from having the ability to proliferate, right? In a normal situation, those T lymphocytes, your body would recognize it as foreign, launch an attack, and kill those cells. However, if you have the same HLA type as the donor, then your body will not recognize them as foreign, and that attack will continue. Okay. That's a huge concern. If any of you guys ever donate blood or bone marrow, anything for your sibling or a first-degree relative, the closer your HLA type, the more at risk you are for graft versus host disease. Okay, and so that's why bone marrow transplants, before they're transmitted, they will be irradiated. Okay. So Sarah, it doesn't help that the HLA is the same. The recipient recognizes the donor T cells as self instead, which allows the donor T cells to go on a rampage. Yes, that's what happened. So it's not the HLA antibodies causing the problems, it's those T lymphocytes attacking the tissues. And so the recipient can't recognize those T cells as foreign because the HLA antibodies are the same. So then the tissues still are getting attacked. Does that make sense?
Does that mean if we're giving blood back and forth, we don't want an HLA match?
You don't want to, you want to have, so there's like 3 classifications of HLA. You want to, if HLA is not a concern, then you want, it doesn't matter. Yeah.
In the instance where we're doing that and it does matter, we don't want matching HLAs for blood, but do we want matching HLAs for like?
For bone marrows, when we start talking about bone marrow transplant, for bone marrows, HLA is more important than ABO match. However, any type of organ transplant, ABO is more important than HLA. So like liver transplant, kidney transplant, it's more important to have a ABO compatible donor. Now there are some classifications of HLA, there's 3 different classes. They might try to get like 1 match in there. So, and we'll talk about that as we get further on into blood bank. But irradiation prevents graft versus host disease. And you guys remember, this was my one FDA reportable error. We had a known multiple myeloma patient that received a non-irradiated product. And it just because he came into the ER was assigned a new medical record number. So it looked like to us, remember I said our system didn't communicate to each other? It looked like to us that he was a brand new patient with no history. So they transfused him a non-irradiated unit. So this is what your irradiator is going to look like. It's a unit, and I will say, I was not here at UAMS when the UAMS has its own irradiator, when the irradiator was installed, but I was told, because it does have a cesium core, and you can apparently build a bomb with it, the whole I-630 interstate, when it was being delivered, was shut down. All right? And so it is, when we go to the blood bank, I will show you, it is on lockdown. It's in its own little room by itself. The door is badge access, and you have to have a background check to get access to it. So now the FBI does have my fingerprints on file. So unfortunately, and it is lead plated to the floor. And if you guys know any history about UAMS, you know they built a new hospital, and blood bank is kind of in its own little location. We're still in the old hospital, and I always wondered why blood bank got left out. This brand new, nice, clean lab got built, and blood bank's still over here by itself. But it's because the irradiator was lead plated to the floor on lockdown, and they could not move it. So blood bank had to stay in its original location. So that's why, all right? So there's different ways you can irradiate. UAMS has the cesium. You could also have a cobalt. You could also use some ultraviolet or X-ray, all right? So UAMS has the cesium. And again, it's just preventing the proliferation of those T cells to help prevent graft versus host disease. I put this in there just to explain what happens in the graft versus host. So we will also irradiate for intrauterine transfusions, neonatal transfusions. All right, they will all be irradiated because these patients are immunocompromised, right? And so we want them to accept the red cells without having any complications from rejection. Okay. All right, expiration time for irradiation. Once you irradiate, that changes your expiration date to 28 days or the original date, whichever comes first. Okay, so if you have a brand new unit that you just received from your donor unit and it's 35 days out from its expiration and you irradiate it, you have to change that expiration date to 28 days instead of 35 days. Okay, however, if you have a unit of red cells that expires next week and you irradiate it today, that expiration date remains the same. Okay, does that make sense? And so why does it change the expiration date? We have to take into account that irradiation also will affect our red cells. Okay, so while it deactivates all of those T lymphocytes, it also has an effect on the red cells. And it's going to cause some red cell membrane damage. So you're going to have some released potassium. So after irradiation, you're going to have increased potassium. And then the cell is going to actually lose some ATP. All right, and so that's why the expiration date changes after irradiation. So that change, however, your cell's function remains the same, all right? Those cells, even though they've lost a little bit of ATP, increased potassium, they still have oxygen carrying capabilities, and your platelets are still activated because we will talk about you can irradiate platelets as well. And so if you irradiate platelets, it does not affect their function, okay? All right, this little excerpt about CMV negative blood. Really, you concerned about the transmission of CMV in any immunocompromised patients, such as our neonatals, intrauterine transfusions, bone marrow transplants, those patients that have HIV, organ transplant patients, any immunocompromised patient, all right? So only 20 to 40% of donors are CMV negative. Okay, so if you guys, any of you happen to be CMV negative, that means you have never been exposed to the CMV virus, all right? Because once you're exposed to it, you're going to build antibodies, all right? Then you have those antibodies for the rest of your life, of course. right? It's only 20 to 40%. So if you're CMV negative, those donor facilities find out you're CMV negative, they're going to call and harass you, right? Because you are primary baby blood, especially if you're O negative, okay? And I put this in there. So remember, leukoreduction is really replacing the need for CMV negative, right? So don't be surprised. You enter your internship to start working in a blood bank, they no longer worry about CMV. All of their products are leukoreduced, okay? All right, so then we can freeze our red cells. And when we say freeze, we're going to add a designated amount of glycerol to these red cells. What the glycerol is going to do, and it's going to prevent ice crystals from forming, and it's going to prevent the cells from dehydrating. So I don't know if any of you guys know what happens when you freeze red cells. They lyse, right? So if you freeze them and then thaw them out, all of the cells will lyse, all right? So we need to prevent that lysing. Glycerol helps with that, prevents the hemolysis of the cells. Okay, so you can add glycerol, then you can freeze it. Put it in a freezer, minus 65 to minus 70 degrees Celsius. It's good for 10 years from the date of collection. Okay, so you can keep it frozen for 10 years. All right, so you can imagine you're freezing it and it has to go in its own little special pouch. I think it's in like a cardboard box, and then it's kept at a minus 65 freezer. So you can imagine there's a process to thaw it out, all right? Number one, you want to deglycerize it. So you're going to go through a series of washing. You're going to add different dilutions of saline and wash it very well. What happens if you do not wash that glycerized unit of red cells appropriately? What happens if there's glycerol still remaining in that unit? Could potentially be transfused to the recipient, which could cause cell lysis, all right? So then it could be harmful for your recipient. So it's very important when you are thawing a frozen red cell that you have adequate washing, okay? Some examples of when you want to use frozen red cells: if a patient has a very rare antibody to maybe a public antigen, okay? Or private antigen, or no, public antigen. So not very many people are antigen negative, okay? They could freeze their blood. Maybe not so much little e, more Lutheran B, maybe a Diego, Chido Rogers, some that you haven't even heard of. Those would be ones that people would freeze those. If you're Bombay, okay, probably definitely want to keep frozen stock. But it does cost, you guys. If you have your blood drawn, it does cost you to store it. They will charge you for storage to keep it at that temperature, to monitor it. Just like when we start talking about any of you females and you have children, you can choose to store your cord blood. Cord blood has stem cells in it. If anybody develops leukemia or any type of hereditary condition, those stem cells are proving to be very invaluable. So you can store that. It's very expensive, but you can. And when Harper was born, I donated mine. Donated the cord blood. Here we have a cord blood bank here at UAMS. So. All right, so that's one reason. If you have a weird phenotype, those patients can choose to freeze their blood. Oh, Sarah has a question. Sarah, that's a really good question. Sarah asks, why is the volume so much lesser than other packed red cells? Think about what happens in the washing procedure. You're going through several series of washes. You're adding saline. That saline is being pulled off. You're going to lose some cells in that process of washing. That's why your volume is going to be so much lower. Sarah says naval ships use deglycerolized cells for deployments. Did not know that.
How long can you keep the cord blood for?
Could, you know, I'm not sure.
So just keeping the stem cells?
Uh-huh. Interesting. All right, so for patients that have a weird phenotype or Bombay, that's the #1 reason that you could choose to freeze cells. If it's, or if it's antigen negative for a very rare antigens that you could, some donor centers will freeze blood like that if they have if their donor has a very weird phenotype, and then they have a hospital that requests it, then they can pull that out of the freezer, deglycerize it, wash it, and then send it to the hospital for transfusion. Okay, so once you freeze your red cells, when it's stored at -65°C, it's good for 10 years. Think about what happens after you wash that red cells. It's washing, all right? It's only good. Your expiration changes to 24 hours, okay? And then after washing, it's just like a red cell unit. You want to store it at 4 degrees, right? Refrigeration. Some limitations for our deglycerized red cells: no platelets, leukocytes, or plasma. Again, just strictly red cells. And again, it can cause hemolysis if glycerol is not removed appropriately. So make sure you have good cell washing. So your outcome of these transfusions, whether it's washed, irradiated, leukocyte-reduced, it all remains the same at how much your patient's hemoglobin and hematocrit should increase, all right? So whatever attribute you have done to the unit should still raise your hemoglobin by 1 gram per deciliter, or that hematocrit should increase 3%, okay? And you guys all know how important clerical check is in blood bank. Make sure you have the right patient, medical record number, ABO compatibility, all of that. So before that unit is issued, 2 people in blood bank have to confirm it, okay? And then once it's up on the floor, 2 nurses have to reconfirm it before the transfusion begins, okay? And we start talking about transfusion, they will go through the form that has to be completed. And that is a permanent record. It stays in your patient's chart forever, okay? And so they'll take vitals. They take vitals, patient's pulse, blood pressure, temperature before the transfusion, and then they will take it every 15 minutes during the transfusion, all right? So vitals are very important. That's how they can identify a transfusion reaction. So if their temperature started out at 98.6, and then it jumps up to, usually you have a plus or minus like 1 to 2 degree. All right, so if it jumps up to 99.5, that could indicate a transfusion reaction, okay? They will use an 18-gauge needle. They'll have, overall, they have 4 hours to complete the transfusion, okay? So they can control the rate drip. They have to have that in by 4 hours. Okay, usually they'll get it in within 2 hours at the max, but they have that 4-hour time frame. And that's just because the longer that unit sits out at room temperature, the more risk for contamination, okay? And it's very important before you guys issue these units on patients that all of your testing is done. That patient's ABO, all discrepancies have been resolved. The RH has been reported out. Your IAT has been performed. If they have any antibodies, then these units have been cross-matched, okay? And then the clerical info will be checked. I mean, twice in blood bank and then again by 2 nurses at the patient bedside.
Is the exception to that for trauma patients that need blood,
yeah,
negative blood.
Yeah, and we'll talk about that too. We'll talk about emergency release when maybe the patient's identification is unknown. In those instances, I don't know if any of you guys know what the hospital does. If they have a patient that comes in unconscious, they're given like an unknown. So their last name might be unknown, and then they'll have like a series of letters and numbers as their first name. Simply like a John Doe. And so then we would cross-match units on, if we have a sample, we could receive a sample on that unknown patient and then we could use that sample to cross-match units and do his testing on. Then once we know his name, then we have to update our records. So, if you have a trauma situation, you don't have a sample and you're issuing out uncross-matched units, we give them O negative. So, and that's all we do. So no cross-matches are being performed, no testing has been performed. We're just hoping and praying they don't have any unexpected alloantibodies. So in those situations, you have to outweigh the pros and cons. Obviously your patient is bleeding out, they need some oxygen carrying capabilities, you accept the risk. So the ER doctor will sign a form saying that he is aware this is uncross-matched blood and I will not hold blood bank liable. So. We have a future lecture that'll talk about emergency release and massive transfusion protocol. Okay, so now we're going to move on to platelets. All right, so platelets, you might also hear it referred to as random. These are prepared from the whole blood collection, okay, after your double spin. So remember that whole blood unit goes through a soft spin first, separates your red cells from your platelet-rich plasma. So your platelets are still suspended in the plasma. Then it's going to go through another centrifugation, separate the platelets from your plasma. Okay, so that's your platelets, your random platelets. Usually, when you do it this way, when it's collected from a whole blood collection rather than the apheresis technique that we're going to talk about, you don't get very many platelets, only about 50 mils per unit. Okay, that is not considered a therapeutic dose. So what happens is, in order to reach that therapeutic dose, we have to pool the platelets together. Oftentimes, it is, you'll pull like 6 to 10 platelets together. Does anybody see an issue with that? 6 to 10 units of platelets from multiple donors, all right, all in one unit going to a single recipient. You see the exposure there. All right, one recipient is being exposed to potentially 6 to 10 different donors in one transfusion. Okay, so that's the limitation, the downside of platelets from a whole blood collection. You will not see these very often anymore now that apheresis has come to the scene and is very prominent now. You can do apheresis where you can get a therapeutic dose from one donor, all right, and that's called a single donor apheresis unit. That's what most clinical hospitals will have in their stock, okay? Just because you don't want to expose that one recipient in one single transfusion to 6 to 10 different donors at one time, all right? A little bit of quality control that you guys need to know. In this one unit for random platelets from the whole blood collection, your platelet count must be 5.5 times 10 to the 10th, all right? So that one unit should elevate your platelet count by about 5,000 per microliter. So if you're ever wondering how your platelet responded or your patient responded to that platelet transfusion, we're going to constantly check their platelet counts. Okay. All right, platelets are stored at room temperature, 20 to 24 degrees with constant agitation. And so when we go to blood bank, I'll show you what that looks like. It's like a little cabinet. The door is open, it's kept at room temperature, and the shelves constantly agitate. All right, and then the platelets just lay flat on in the shelves, kind of like drawers, they pull out. And then that's how your platelets are stored. Your expiration time is 5 days from the date of collection. All right. Remember I said that these random platelets do not really have a therapeutic dose. All right, so they are pulled together to reach that therapeutic dose to have the ultimate benefit for your patient, while at the same time exposing them to multiple donors. So that usually ends up being about 6 to 10 platelet concentrates. All right, so uses for platelets, if your patient had any type of bleeding, thrombocytopenia, or they have some type of platelet function disorder, then they will need platelet transfusions. However, if your patient has a platelet consumption disease, such as ITP or TTP, where your patient is destroying platelets, all right, that your platelet transfusion is not going to help them because the patient's just going to destroy your donor platelets as well. All right. Oftentimes, it's better to treat these diseases rather than give them a platelet transfusion. Okay. When you think about platelets, ABO is not as huge as a concern. They do have a little bit of plasma mixed in with those platelets, all right, just a very small amount. So we try to give ABO compatible, but it's not absolutely necessary, okay? So don't be surprised if you work in blood bank and you have a B patient and you give them A platelets, okay? It's not uncommon. And just like red cells, usually your hospital will have a threshold before you can transfuse platelets in a patient. Usually it's 10,000 to 20,000. All right, so if your patient presents with a platelet count of 20,000, that might warrant a transfusion. For chemotherapy patients, those patients that are known leukemia patients, their threshold might be a little bit lower, 10,000, before the physician will transfuse them. So patients that require platelet, cancer patients, those that are undergoing chemo, just like our red cells, right, they will receive multiple platelet transfusions. Stem cell recipients after a transplant, post-operative bleeding patients, and then organ transplants. So do you see, these are our common populations of patients in blood bank, all right? OR, ER, chemotherapy, those are the ones that we work a lot with. And again, usually you're going to pull them 6 to 10 units, and that should raise your platelet count. So if one single unit raises it by 5,000, if you pull it, then your total platelet count should increase by 30 to 60,000 per microliter. Okay. All right, so that's lecture 16. We talked about whole blood, we talked about packed cells, we talked about washed red cells, irradiated, Leukocyte-Reduced, and we talked about platelets from whole blood. Okay. Does anybody have any questions on the products we've talked about so far?